So we're going to wind down and we're going to finish off with the turn of the century, meaning 20th century up to the 21st century. We're not going to go all the way to current times because that becomes very problematic. When we start talking about issues, problems, current times, then it becomes very controversial and complicated. And, so there's people doing the stuff you comment on it, and you try not to do that. Of course, when we talk about the late 20th century and the turn of the century, people right now are actually doing extrapolations of those things which started in the late 20th century and turn of the century, right? Especially if you're talking about developing countries, because from the way it looks, the developments in the developed countries translate into the developing countries or the westernized countries or countries who try to emulate or follow the developed Western countries. And there's usually a lag of about 15 to 20 years for some. Any kind of field, there's a lag in translation, and there's all sorts of factors, but we won't go into that. Sometimes it's faster, especially if the commercial incentive or the motivation to translate it faster is high. Usually there's a lag. One reason is because the resources and the number of people who will benefit from it is, they're not as rich as the developed countries. By definition, it's not there. There's no critical mass. So why would you bring in the modern technique or modern science or modern expensive stuff into a country where there's only a few people who benefit from it? There's other reasons, but we won't go into that. So we'll try to finish up at the turn of the century. So we'll start with promoting the core ideas. This happened 1 to 2 decades after people started creating the field. So they started creating the field in hospice and palliative care nursing, hospice and palliative care medicine for doctors, and then the social workers started following suit because, it's not just nurses and doctors. When you're talking about the terminally ill and they're in the hospital, and the thing that's happening during those times is send the patient home. The thing that got developed really fast in the field is home care. And we discussed that in the previous sessions, so we won't talk about it right now, but that's the thing that sells. So going back to the situation, that they're still at it. So some of them are still idealistic, and they say, what should we do? Well, we want to change them. So let's convince the American Medical Association or the Canadian Medical Association to put some funds in so that we can start some kind of workshop or awareness program and things like that, so that all the doctors, by the time they graduate, or even those who are working, will know how to take care, or will realize that they have to take care of the terminally ill. It's not just about curing. We know your situation right now. We know that you're very excited about the whole curing thing, and all this money pouring in, and all these conferences and things like that. And we know that you're not seeing a lot of the motivations and incentives as far as taking care of dying people are concerned, but we want you to be aware that you also have to do it. So there's an awareness thing going on, and preferably we do that for all the practicing doctors who are about to practice. And let's start with the values and attitudes of the students, because everything gets started in medical school. Actually, things get started even before medical school. When you're a kid in college or high school, and you open the television and you see the kind of doctor that's being projected, the kind of lifestyle and the kind of medicine that's being projected or being described on television, fancy cars, and it's like there's no difference between the drama between high-end corporate lawyers. Now they have the drama in hospitals and money and things like that, with a little bit of emotional, dramatic stuff going on. That's the medicine that gets into your head, right? It's becoming more averse to the depressing things like suffering, someone about to die, the terminally ill, and things like that. When we watch a television show, we want those things in the climax, and in certain parts of the program, we don't want to see a whole bunch of death and dying and suffering all throughout the program, right? If it's a 30-minute show, we don't want to see a lot of death, dying, and suffering for 20 minutes. A nice little drama and emotional and crying for about 2 or 3 minutes, and that's pretty much as good as it can get. And the rest should be lighter and more positive. So anyway, so you kind of start there. So you start telling the kids that this is what medicine is all about. So when you go in, when you decide you want to be doctors or nurses or care providers, this is really what it is. This is the oath. This is how we describe it. You open the book. This is what it is. We give you the definition. This is what you're supposed to be doing. And then they go into the environment of medicine and to the hospital, see their consultants doing something else, thinking something else. There's a discrepancy between what the book says and what the lecturer says. And unless the lecturer is really very proud of whatever his values are, he's just brandishing it all over the place. Of course, you can only do so much. If it's so bad, you don't flaunt it, right? It's getting worse. But anyway, it's getting worse. That's what you learn. This is what you read. This is what's spoken, but this is what everyone is doing. And which is a stronger way of learning, the role modeling, right? So, I mean, sitting down and listening to and looking at the PowerPoints and listening to someone talk or reading a book, and then you're about to graduate and you want to be someone successful, and you look at the people around you or the successful people around you, and this is what success means, and these are their values and attitudes. But that's role modeling. You follow them, you don't follow the PowerPoints, and you don't follow the book. So you start there. So what did they do? Well, in some countries, especially if they have funding, they give money to do nationwide workshops. For all doctors, you create a CD. Of course, you have CDs during those times, and you don't have great internet Wi-Fi yet. You create programs and you put them in CDs, right? And then you send it all over the place, and then you go all over the country, and then you do the workshops. This is what palliative care is. Everyone should be doing this. You should learn communication. You have to learn how to communicate bad news. It's part of your job. You're the best one to do it. It's so easy. This is how you do it. When people die, you sit down, and these are the psychosocial supportive stuff that you need to do. But just in case symptoms happen, usually those symptoms you can easily manage, and these are the most common symptoms, very, very near death. And actually, there's not a lot of medication that you need to memorize. There's the dozen or half dozen medications you need to know about. You actually know about them because these were not developed for terminal care. You know about opioids, you know about analgesics, sedatives. Like even in an internship, you can do that. And the principles of using them are so simple. The big ones would be, when someone's about to die, you don't think about whether it's going to cause side effects years from now or weeks from now. You think more about this person hopefully doesn't die suffering or in distress. And if the person is about to die in 3 to 6 hours or 2 hours in severe distress, in severe pain, in severe dyspnea, you don't think about maybe I shouldn't give too much because this person might die. Or maybe I shouldn't give too much, this person might get addicted, which is ludicrous, right? It's really stupid, right? So, it's a stupid idea. This person might die. This person is dying. So it's a choice between the person dies somewhat comfortable, not in severe distress, or the person dies relatively comfortable or with less distress, right? Addiction. How can a dying person there's no time for this person to get addicted. More than likely, they really need the medication to begin with. So those kinds of things, that's like common sense stuff. And since the person's about to die and the organs are failing, then if you want, you start with a lower dose. It might work. Actually, we already have clinical studies to tell you how you should start and to guide you how you should start. But the basic idea is, you can start low, but then, you only have 3 hours and you don't want this person to die suffering. So if your first dose doesn't work and you know the time of action, then you should increase the dose, because you don't want to be titrating all the way until the patient dies and you haven't gotten the right proper dose and the patient actually died suffering. Those are really common sense stuff. The only thing that might be specialized would be grief counseling. Of course, grief counseling, there has been grief counselors even before they created hospice and palliative care. So that's what the workshop is all about. The most important topics everyone should know about. And then there was an advocacy group that's asking the residency programs and all the training programs for nurses and young doctors, and even nursing schools, medical schools, or social work schools, that they should have subjects and exposure and training about caring for those who are near death, the terminally ill, those who are dying. That's pretty successful. If you look at all the curriculums right now, everyone has some form of end-of-life care inside their curriculums. The developed Western countries have done it already. The westernized countries or the developing countries are following suit. it's a done deal. It's already there. Of course, the question is, putting it in the books and the textbooks is one thing, but are they actually going to do it? Because it takes a lot of time and effort, and it's not going to pay you much. Of course, the answer is, well, it depends on the attitude and values. And we already talked about attitudes and values. So the answer is, if you look at things globally, especially in the centers of training, like, big metropolitan areas and big centers, the answer is no. They're not motivated to do that. Their sources of motivation is not there. It's somewhere else. So anyways, that's what happened during the turn of the century. Attempts were made to try to create awareness, try to promote teaching, making sure that all doctors know what to do, telling them that they should do it, starting in med school, getting the idea into the curriculum and things like that. That's 20th century stuff in the developed countries. Of course, it happened in the developing countries 1 or 2 decades later. So that's what happened. Of course, we won't go. There's so many things that happened during the turn of the century. But the other thing that happened is, just like primary care, or general medicine or general pediatrics, when you try to take care of the most common problems that don't need specialists, there's overlaps. You take care of the hypertension, but you're not the hypertension expert. Now, the idea with primary care is you have one person to do most of it because it's more cost efficient. You have those other people doing the complicated stuff. They know more about it, but you don't need to know all the details to be able to serve a lot of people, or most of everyone. Or if you do diabetes care in the primary care setting, and the endocrinologist is the expert. So there's overlaps. That same thing, there's an overlap that happened with hospice and palliative care, especially once the medical community became convinced, or the environment was right for the medical community to pay attention to it. The first thing that we can look at is this quality of life thing. We talked about it, and it's one of the definitions: decrease the suffering, decrease the decrease the distress. If you want to do that, that's what we talked about in the first session of this series. But then the other way of putting it is optimize the quality of life of someone who is terminally ill with far advanced illness, right? And if you have far advanced illness that cannot be completely cured, and we're running out of ways to prolong your life, then we just need to optimize the quality of your life so that you can live your life fully until the day you die. That's the hospice and palliative care idea, right? Now, when you say quality of life, there's also another field who talks about quality of life. If you have a broken back, a spinal cord problem, you have a bad stroke, or you have a bad heart or lung problem, and things like that, aside from trying to prolong your life and cure you, somebody has to take care of your quality of life, right? But you're not obviously clearly dying, right? But there's another person taking care of the quality of life. That's rehabilitation medicine. So rehabilitation medicine does all the stuff for people with functional limitations or disabilities brought about by illness. And of course, illnesses or the diseases which cause really severe functional restrictions or limitations are those which are far advanced, especially those which the other specialists cannot cure anymore, right? That's it. So you can see the overlap, right? So of course, this is more focused on the function. But then when you talk about overall functioning of the human being, so what do you actually mean? Well, he's functioning in life, meaning he's living out his life. So they actually also used quality of life, because that's what function is. And you're not functional if you have emotional problems, right? So you're not going to think straight if you have cognitive problems, right? Aside from physical functioning. So it's a holistic approach also. So you can see the overlap between rehabilitation medicine and hospice and palliative care. The only difference is the type of patients they initially addressed, or they're addressing right now. Hospice and palliative care, people who are really, really far gone, and you're talking about just a few months to live, but still a functional problem or a quality of life problem. You're still dealing with emotional problems or cognitive problems that prevents you from living out your remaining life fully. The rehabilitation medicine people are dealing with those who are not there yet, but where's the dividing line? You need more and more rehabilitation and optimization of your functioning until you're bedbound. But still, when you're bedbound, they do all sorts of things so that your muscles don't atrophy, so that you can still move around in the wheelchair and things like that. So where's the dividing line? And the answer is there's no dividing line. They kind of overlap. So that's the reason why it kind of overlaps. And these rehabilitation medicine groups, some of them are fairly well established inside cancer centers. When the cancer doctors in this cancer center said, we have to improve their quality of life, and there wasn't any hospice and palliative care yet, or when somebody says hospice and palliative care, they think about home care and dying at home and things like that. They think about rehabilitation medicine, improvement of the quality. They're not dying yet. I mean, they have still lots of months or maybe even years to go. So that's called their rehabilitation medicine. People with advanced heart failure. And if you think about it, if it's so far advanced, you actually might have the prognosis comparable to someone with really advanced cancer, but nobody thinks that way yet. Would get cardiac rehab. Someone with really, really bad lungs who's supposed to go home, who might have really bad prognosis, probably won't get referred to hospice and palliative care unless they're really about to die, but they'll get pulmonary rehab. So there's the overlap. And since some of these rehabilitation medicine centers or groups are inside the cancer centers, and we know that during this time, cancer is the main client of hospice and palliative care. For another reason, we'll talk about it a few minutes from now. And these rehab people are already adept in doing research as far as improving function and quality of life is concerned. A lot of the advances, or a good chunk of the advances in palliative care, came from rehab centers which were expanded to include palliative care. A lot of contributions came from centers like this, especially as far as the clinical interventions are concerned. And then the other groups which paid attention to it more would be the cancer doctors. Because there's no dividing line. How sick is sick enough, right? So the palliative care people started telling everyone, we have this line. You start at the beginning. You start paying attention to palliative care at the beginning and quality of life. And then if the patient's getting worse and worse, then you do more and more of it because it becomes a bigger problem. Right near the end, there's not a lot of curing or life prolonging things you can offer anymore. So it's mostly improving quality of life and providing comfort. Right? Of course, the question is, when do we call you up along these lines? One answer is you call us up right from the very start. Now, of course, the idea is, but you have to supply us with a lot of manpower because, that's a lot of people. That's practically everyone in the cancer center. Right? So you call us up right from the very start. A more obvious practical thing that goes along with the initial intention of the entire movement is, well, if it's early on and it's not that complicated yet, you and your staff should be doing most of it. Now, if it becomes too complicated, especially near the end of life and you're too busy, then that's where your palliative care team or your specialist comes in, right? Same idea with hypertension or diabetes and things like that. Do not make this patient go to the specialist, pay twice as much as he is paying you for the diabetes, and then make this same person go to another specialist and spend the same amount for the hypertension, when in fact you already knew what to do even during internship, right? So, you're not just the referral guy who takes care of coughs and cold. Of course, the incentive is to see more. It's like a fast food center. You earn more if you see more, and if it's too complicated and it takes up more than 10 minutes of your time, you will send it to someone else. But that's not the original idea of advancing or promoting generalist practice. Those are the problems and ills of modern day primary care or generalist care. Now, how the cancer community took it, well, it comes in various flavors. Some small centers are very busy and they don't see a lot of financial and other motivations going into it. Are so happy that there's a group of people who will take care of all their problems. Anything from disclosure to taking care of the dying person, which doesn't require a lot of cancer treatment anymore, to taking care of this person when this person goes home. That frees up a lot of their beds. And of course, there's a lot of motivations going into that. We discussed that, I think, in the second session. So they wholly embraced it. Now, the bigger cancer centers already had things in place because they're the model programs. So they already have rehab going on. They already have supportive counselors going on, or supportive care nurses who are aware of the support needs of people who are very near the end of their life or with very advanced cancer, they already have things in place. And so when they saw this palliative care idea, some of them would say, well, we already have that. All we need to do is just reorganize the entire thing and call it palliative care. And that's what happened in some places. But they're only concerned with cancer patients. So what do you call it? Well, you can call it palliative cancer care, right? Which didn't, I don't think people thought about it. It's such a cumbersome way of calling it. The very common term is supportive oncology. So supportive oncology. You type it, you research it, it pops out, and you look at the inside, it looks very, very much like palliative care for cancer, supportive oncology. Actually, one of the big textbooks, early 21st century in palliative care, was actually called supportive oncology or supportive care for cancer. Now, which brings us to this cancer thing. The confusing situation is, how come you have a field that's supposed to take care of every patient with an advanced disease of any kind, be 70 to 90% cancer care? Why all the cancer? Well, there's lots of ways to explore these things, and we won't spend too many minutes on all the different ways of looking at it. But if we look at the history, there's this group of nurses, including the founder of the modern hospice and palliative care movement, Cicely Saunders. They're taking care of the people outside of the hospital. Nobody wants to take care of them. And some of them are suffering a lot and they're in severe distress. So first of all, the patient shouldn't be dying suddenly. They have several days to work on the patient. So that takes out the advanced diseases that kind of kills you suddenly. You have a stroke or you have an advanced heart failure, you're going home, you're walking around in oxygen, suddenly you have an arrhythmia or a bad heart attack and you're dead. I mean, those people are not usually lying down in the hospice care halfway houses that the founders were working on, right? They were not their clients. And they're not probably the Alzheimer's patients. They drag on, but they're functionally impaired and they're not suffering, but you have to take care of them. Somebody has to nurse them and their family issues. They're not those people. Usually the neurologists and the neurological nursing care staff came up with ways to take care of them. But, in your mind, conceptually, they're also dying. It's not the classic way. The classic way is somebody's terminal and then progressively in a span of less than 2 years or less than 1 year usually, they get worse and worse. And whatever this disease is causing a lot of symptoms. And it needs a doctor to take care of the symptoms. So what you're looking at is a solid tumor or a solid cancer or a cancer that's difficult to cure, that keeps on growing, keeps on spreading, causing a lot of problem before the patient dies. So you're looking at that disease. So what disease is that? That's cancer, right? So perfect client would be people with cancer, right? Or adult people with cancer. Kids follow a different course, and success in treating cancer in kids, especially hematologic cancer and things like that, are pretty high. So the first clients for a few decades are adult cancer. So that's the reason why hospice and palliative care began to look like it's taking care of people with adult cancer that's far advanced with limited prognosis. Of course, that's not the definition. So that's the reason why when you look around, you see supportive oncology, which sounded like a separate field. And of course, it is a separate field because, they were there even before palliative care. Of course, they're just focused on cancer. I mean, you open up their literature and their textbooks and their training programs, it's not going to talk about people with advanced heart disease or lung disease who are dying. So they started expanding and telling everyone that's not really it. And they started taking in more people with really advanced organ failure, like advanced heart disease, who look like they have the prognosis worse than cancer or worse than advanced cancer, or advanced lung disease, advanced kidney disease, okay, so advanced liver disease. So we have that.